let's move on from EKGs, EKG strips, interpretation, and then let's focus on some more perfusion type disorders, things that are gonna alter my tissue perfusion, alter my cardiac output, pretty much altering my vital signs, things that are gonna hurt me from that perspective. I've updated the PowerPoint probably since y'all downloaded it, I'm sure. There says DIC at the bottom of all y'all's. Okay, mark out DIC, we're not gonna talk about that for this test. It's gonna be further on for OB, okay? So don't even worry about DIC for that. Well, we're gonna cover 3 separate categories or areas. We've already talked about SHOP before in previous semesters. We're gonna go a little bit more in depth. We're gonna kind of review or think about what we talked about last semester with SHOP and the different types. And then go in a little more in depth. And then Dr. McCarty talked about cardiogenic shock last week as well. So remember the key points that she talked about as well. We're also gonna talk about valve disorders or valvular damage, valvular disease. You'll kind of see it called a couple different things. Something like a valvular disorder, valvular disease, or valve disorders. And then rheumatic endocarditis, real fancy term for some type of infection around the heart. So let's talk about rheumatic endocarditis. With rheumatic endocarditis, let's break it down. So let's not worry about rheumatic just yet. Endocarditis. What does endo mean?
Heart.
Endo. Inside, all right, so heart, or cardiac, right? Itis.
Inflammation.
Right? So inflammation inside the heart, right? That's what we're thinking about with rheumatic endocarditis. At some point or another, I've had a streptococcal, a group A streptococcal infection that either wasn't adequately treated or wasn't treated at all. Some point in my life, I've had that. So something like scarlet fever or even strep throat, maybe something along those lines. I've had that infection before, it's gone away, it's gone dormant. During that period, or in the meantime, my body has developed some type of sensitivity response, immune response to that streptococci bacteria. And that's how we're getting this rheumatic endocarditis. So some type of sensitivity response that develops after an upper respiratory infection with a group A beta hemolytic streptococci. Your big bullet point here is going to be occurs in almost half of your rheumatic fever type patients. Rheumatic fever, think rheumatic endocarditis. With that, we're going to have an inflammation around that heart. It's going to affect the myocardium, the pericardium, and then those valves. The valves are going to be what's important, what we're going to focus on, because that's how we're going to get into those valvular disorders in just a second. So it creates these small little nodules, these little spots, little scar tissue areas that's going to cause that valvular damage. That can cause some of that valvular stenosis or that valvular regurgitation. And we're going to talk about those in just a minute, but that's how it's getting to happen, the characteristics of this rheumatic endocarditis. I would probably highlight this whole section right here, that last bullet point. That's what's important about that rheumatic endocarditis. It causes damage to those valves, all right? Let me read it for you. Most serious damage occurs to the endocardium with inflammation of the valve leaflets developing. Hemorrhagic and fibrous lesions form along the inflamed surfaces of the valves, resulting in stenosis or regurgitation of the mitral and aortic valves. Hemorrhagic and fibrous lesions inflaming the valves, and it's going to affect the mitral and aortic valves, whether it be stenosis or regurgitation. Yes?
Is this what they refer to as like vegetation or whatever?
We can have vegetation in the heart. very similar to this, related to this. But vegetation can also be things from, there's one that's called infective endocarditis, which is a different bacteria that can cause vegetation around the leaflets of the valves. Other things like IV drug use as well, using a dirty needle to inject. So we're introducing bacteria into that bloodstream, and so that bacteria likes to accumulate around those valves, and so we can have vegetation throughout that heart, those heart valves. Let's talk about our signs and symptoms. Big things, your cardiomegaly, so an enlarged heart. Remember, my heart is getting inflamed. It has this infection, it has this disease process that's occurring, creating those small little nodules, those little lesions around the valves, around that myocardium and that pericardium. So we're having that enlarged heart. With that enlarged heart, these things make sense. A pericardial friction. So if that heart is a little bit bigger, it's rubbing up against that pericardial sac, right? Creating that friction. Probably gonna have a little bit of chest pain with it, because I'm having inflammation, I'm having that little hemorrhagic lesions, nodules in my heart. That's gonna cause me to have a little bit of chest pain, or that precordial pain. Remember, we just talked about that prolonged PR interval. So something like that rheumatic endocarditis could be that prolonged PR interval, greater than 0.2 on the boxes there. Heart failure. What are some signs and symptoms of heart failure? Your thoughts? Edema. So it's going to be dependent on the right side versus the left side of heart failure. So right side of heart failure, it's going to be things like edema, JVD, right? Anything else? Exertion, hypoxia. Then left side of heart failure. So you're going to have those wet lungs. Peripheral cyanosis, fatigue, because my heart is not able to keep up with that demand of that body because of the left side of the heart failing. And since this is caused by a streptococcal infection, shouldn't I know if they've had a streptococcal infection in the past?
Yes.
Probably so. So put that on there as well. Treatment-wise, a primary prevention strategy is going to be to prevent that streptococcal infection from ever occurring. They can't develop that sensitivity to it. They can't develop that rheumatic fever that can lead to rheumatic endocarditis if they've hadn't had that streptococcal infection before. If they do get that streptococcal infection, let's encourage our patients to seek out treatments. So if they have strep throat, get treatment. I don't know who says, no, I can handle strep throat because I feel like I'm dying when I have strep throat, and I go seek treatment. And if they get treatment, make sure they take their antibiotics appropriately, make it for the full course. Make sure they're a patient advocate for themselves. Talk to that physician, say, hey, this is what I got, this is what I'm thinking about. I need to be treated adequately. And then also talk to them about those signs and symptoms. People may not even know what this type of stuff is, what strep throat is. How do I determine if it is or not? Is there any tenderness or feel like you're swallowing glass? You have those red in the lymph nodes back there in the back, way back there. That's a pretty gross looking strep throat right there. If they develop rheumatic endocarditis, I can give aggressive antibiotic therapy. So something like a big penicillin or an erythromycin if you're allergic to penicillin. Are you allergic to both?
To stuff and penicillin?
To erythromycin and penicillin?
I can take medicine.
Okay, there you go. So you can be treated for rheumatic endocarditis. Keflex, you can give something like that. The big thing is aggressive antibiotic therapy for a very prolonged period of time. This is not going to be like a 7 to 10 day, I pop a pill, I'm good to go. This is going to be long IV antibiotics. May put a PICC line in, send them home on it, and then they get IV antibiotics for a long course, long period of time. So I would probably note that, long period of time. Adequate hydration, antipyretics, which is what?
Fever medication.
Acetaminophen or Tylenol, help with that fever.
Are you not going to do nothing for inflammation?
Inflammation, you could, you should give corticosteroids. NSAIDs, not really, but corticosteroids, you could give something like that. And then blood cultures. So what comes first, blood cultures or antibiotics?
Blood culture.
Cultures.
Blood cultures first, right? So if I have an order set and it says blood cultures, antibiotics, give antipyretics, that kind of stuff, what am I doing first?
Blood culture.
Cultures.
Blood cultures first, right? I gotta see what I'm trying to kill. What type of bacteria am I trying to kill? If I give those antibiotics first, it could alter my results. So I need to get those blood cultures first. Do we know how to draw blood cultures? Do you all know how?
Clean,
So clean the sites,
new side,
new site. So we draw blood from one side. How long do we have to wait? Do we have to wait at all, or can we just stick again?
24 hours.
5 minutes.
5 minutes.
Between the bottles?
Between the two vials, so if we're getting two sets of blood cultures, the two little bottles that you have, you're getting two from that one side, the aerobic and anaerobic bacteria. How long do I have to wait until I stick again to get another set? Can I just stick them right away? You do have to wait.
But you're going to a whole new site though.
Gotta wait 15 minutes until you go.
Well, I was 10 minutes off.
You were 10 minutes off. Yeah, so 15 minutes, and that's gonna be kind of facility specific as well, but 15 minutes. And then ask your ICU nurses and other folks if they truly wait 15 minutes, it might be 14 minutes and 59 seconds too early. But it's supposed to be 15 minutes, okay, for that purposes. Gotta allow time for that blood to circulate a little bit. And if we contaminated the first site, or if that site is the one that's infected, then we need to go to the other side to make sure that we're getting a sample. We gotta figure out what's going on with those blood cultures. And then my next big thing is getting that antibiotic therapy going quickly. Right, they need the antibiotics now. Questions are about rheumatic endocarditis.
So do you see this more in kids?
You're usually gonna see it in adults, for the most part. That sensitivity period is gonna lay dormant for a while. And it's really specific on when it presents itself as well. My mother-in-law, she went in to UAB in like 2020, early 2020, and they thought she had rheumatic endocarditis. She had valve repair and all that kind of stuff. Like that picture that my wife showed last week, she was in UAB for a while too. They thought she had this because she had, I think she said she had scarlet fever way back when, and she developed some type of infection, really weren't sure, blood cultures didn't come back, there wasn't any vegetation on her heart, so they're really unsure, but they thought rheumatic endocarditis because of her heart history and running those high fevers and stuff. So they actually sent her home with a PICC line and gave her IV antibiotics. She had the little bowl of antibiotics that you undo the clamp and it just infuses periodically. And she had that for a long, long period of time. I want to say like 6 months or more. I mean, she had it for a while. She had home health come in, check on the PICC every so often, but she had it for a long time. Looking back, me and the wife's diagnosis was COVID, but COVID hadn't came around yet when that happened, and so they didn't know about COVID yet. Either way, she got better, so it didn't really matter at the end of the day. But just a side note there. Questions about rheumatic endocarditis? Very simple, very straight to the point. So let's talk about the parts of the heart. Why is it's cutting into my heart off? That's gonna be,
Don't need that part.
probably gonna be his major malfunction right there. Gonna talk about the parts of the heart, which is gonna lead into our valves and our valvular disorders. But to get a full idea or thought process on how these valvular disorders are going to affect our body, we need to look at the different parts of the heart and how that blood kind of circulates through the heart. So we're gonna go back to Anatomy 101 here. can I get a basic overview? So where does my blood enter my heart?
Superior vena cava.
So the superior vena cava and then that inferior vena cava, right? It's gonna dump into what?
The right atrium.
Right.
Right atrium, good. Where's it gonna go next?
Right ventricle.
Right ventricle, what valve does it pass through?
The tricuspid.
Tricuspid valve, right? So between that right atrium and that right ventricle, we have that tricuspid valve. When does that tricuspid valve open?
When the
When the atrium is full.
Well, the atrium is full. What
when it's
part?
relaxing.
Relaxing. The ventricle is relaxing and the atrial is beating. So what part of the rhythm is that?
P wave.
P-wave.
It is the P wave. Is it the systolic phase or the diastolic phase?
Systolic.
Systolic?
Uh,
The systole is what?
When it's contracted.
The ventricle contracting, right? Because the systole is the big number, right? I need more force, more pressure. So when systole occurs, that's my ventricles beating. Diastole occurs, that's my atrials beating. So my atrium needs to beat to push that blood down into that right ventricle. My tricuspid valve has to open up to allow that to occur. So during what is it gonna open? Stop. During diastole, right? During diastole, that tricuspid valve is going to open, allowing for that blood to fall in to that right ventricle, okay? From the right ventricle, where is it gonna go?
To the left atrium.
Pulmonary artery, good.
out to the
This is the
lungs.
only time the artery is gonna have deoxygenated blood into it. What valve does it have to pass through? That pulmonic valve right there, that pulmonary valve. When is that pulmonary valve gonna open? Systole, right? Because the ventricle's gotta beat and that blood's gotta pass through. So it's gotta open up during systole for that ventricle to beat effectively. Alright, after the pulmonary artery, where's it gonna go?
The lungs.
The lungs, good. Do that gas exchange, get that oxygenation on board. And then it's gonna come back into our pulmonary veins and dump into what?
The left atrium.
Left atrium.
The left atrium, good. Then where?
Through the mitral valve.
Through the mitral valve, perfect.
Then into the left ventricle.
Left ventricle, good.
Then-
Mitral valve, when does it open?
During diastole.
Diastole, right?
Diastole, yeah.
Okay? It's gotta open up because it's gotta allow that blood from that left atrium down into that left ventricle. So during diastole, that left atrium is beating. And then we go into the left ventricle. Where does it go then?
Out to the system.
Out to the system, but it goes to a couple other places first. It goes to the aortic valve, right? When does the aortic valve open? Systole, right? Because the ventricle is beating that blood, perfusing that blood, moving that blood forward into that aorta. So it's gotta open up during systole to allow that to happen. Goes into the aorta, then goes out through the rest of the body. Alright, does that make sense? That was a long time ago, right? Anatomy 101. But we break it down. We all should know this, but just sometimes we kind of forget about these things when we don't actually break it down. Our big thing with our valvular disorders, 9 times out of 10, your aortic valve, so the one in between the left ventricle and the aorta, and then your mitral valve right here between the left atrium and the left ventricle, that's what's going to be affected. Your tricuspid valve and your pulmonic valve are usually not affected by your valvular type disorders. They can happen, but it's pretty rare. We're going to talk about aortic type disorders and we're going to talk about mitral type disorders. So you can kind of forget about the tricuspid valve and the pulmonic valve for now. They still are there, they still are important though. Okay?
Is it because of pressure?
Because of pressure, but it usually settles in on that side. It's just the way it happens. Another example, another definition of where the valves are at in your heart. We won't read through that part. It's a lot of reading right here, I know. But what did I tell you? Mitral valve, aortic valve. So cut the top half off, worry about the bottom half. All right? So your mitral valve, where is that located again?
side of your heart.
Left side of the heart, right? So left atrium and the left ventricle, between those two. It opens during diastole, allowing for that blood to flow from the left atrium down into that left ventricle. And then it closes during systole, because as that left ventricle beats, I don't need that blood to backflow up into that left atrium, right? I need it to go forward through that aorta. Our aortic valve is in between the aorta and that left ventricle. So during systole, as that ventricle beats, I need it to open up, and so that blood can flow from that left ventricle, pump out, and perfuse the entire body. During diastole, I need it to close, because I don't need that backflow of blood to occur back into that left ventricle. Does that make sense? That's what all this stuff says right here at the bottom. It just tells you a more in-depth view. But it really just tells you when it opens, when it closes, where it's located. When I am auscultating heart sounds, do y'all remember the 5 placements and where to listen to each valve? Y'all remember that? Aortic. So tell me about aortic. Where is it located?
And it's right.
Over here. So tell me specifically. Second intercostal space.
Medius.
Right what?
External.
Right sternal border. Good, right? Aortic, right here at the top. Second intercostal space, right sternal border. And then we move on to the pulmonary. Second intercostal space, left sternal border, right? Herb's point, we don't really care about that, but we'll talk about it. Third intercostal space, left sternal border. Our tricuspid valve. Fourth intercostal space, left sternal border. And then our mitral valve. Fifth intercostal space, but we're no longer on that left sternal border. We're mid-clavicular. Left mid-clavicular. So if I was to know this slide, I would know where my aortic and my mitral valves are located when I listen to them, because that's what we're going to talk about as far as valve disorders go, the aortic and the mitral. So remember your mnemonic for this, however you want to say it. I do ape to man. There's a lot of other options out there. I don't really care which one you use, just so you know where mainly the aortic and the mitral valve are located, or where you hear them, where you auscultate them at. So let's look at the differences. So we have what's called mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation. Those are the big ones that we're going to talk about. There's also something called mitral prolapse. You'll see that in your book as well, but we're really not going to use that term a whole lot. We're going to focus on stenosis and regurgitation. So put them side by side to kind of give you a side-by-side view, kind of versus side, what stenosis looks like versus regurgitation looks like. This is also going to be box 29.9, page 707 in your med-surg textbook, the learned one. That's going to be your key features of your valvular heart disease disorders. So let's talk about stenosis. For some reason or another, my valve is not able to open up properly as it should. Could be a multitude of things, but it's really just the stiffening of those valves, or maybe the tendae cordae, or those little muscle tendons, little fibers, little strings, if you will, that are attached to those valves. Maybe they have stiffened up and they're not opening up and pulling back to open up that valve like they should, or those valves are stiffened, they're calcified. That's why it's not allowing for that valve to fully open, allowing for that blood to move further downstream. So again, the valve does not open properly. It narrows that pathway of the blood flow. With that, my heart has to work against that stenosis, because my valve is only, say, opening halfway. My heart has to beat a little bit harder, work a little bit harder to pump that blood through that halfway open valve. With that, my oxygen delivery is gonna be off. My cardiac output's gonna be off. I'm gonna develop symptoms of all sorts of kinds depending on where this is occurring, either the mitral valve or the aortic valve. So that's why it's important to know when the heart valves are opening and closing. Because then I'll know if I'm talking about a stenosis or if I'm talking about a regurgitation. So regurgitation, let's look at the other side. Some type of reason or another, my valve is not closing appropriately as it should, not creating that adequate seal. So when that heart beats and that valve is closed, it's allowing blood to backflow from that previous chamber, all right? Because of that improper seal, it can kind of leak back through, get that backflow from occurring. That's where you're gonna get this prolapse in there as well. So some type of prolapse where the valves don't shut exactly close or sealed together. They kind of shut on top of each other, kind of that prolapse look appearance. So like I said, that backflow of blood into that previous chamber, that's where it's gonna happen most. Again, it's gonna reduce that oxygen delivery because it's not delivering that full amount of blood like it should. Part of that blood went back up to that other chamber, the other half is moving forward. So I might be only getting half of that oxygen delivery that I would originally get if I didn't have any regurgitation. With that fluid back up, it's gonna cause things to dilate, things to get backed up. My heart muscle is gonna have to work a little bit harder again because of that extra fluid that's on board. And we'll talk about these things, we'll look at these things. Again, your symptom presentation is going to be based on where the valve that we're talking about is. So that's why, again, it's important to know when is that aortic valve opening? When is it closing? When is that mitral valve opening? And when is it closing? Okay? Questions about stenosis versus regurgitation? Just another picture of kind of showing you the basic concepts of the heart valves. Again, we're talking mostly about the mitral valve, and then we're going to talk about the aortic valve down here as well. So these basically two systems on the left side of that heart. That's what we're going to focus on mostly. Mitral stenosis. So what was stenosis for us? Was it an opening problem or a closing problem?
Open.
Opening.
An opening problem, right? My valve is not opening efficiently or properly as it should for some reason or another. So it could be that stiffening of those chordae tendineae right there. So those little strings that's attached to those leaflets, they're not opening and closing efficiently like they should. Maybe I have calcification around that valve opening, so it's narrowing that opening and then not allowing for that valve to be kind of pliable, allowing for that good blood flow to occur. So this right side over here, good representation of your normal valve, how it opens versus that mitral stenosis and how it's kind of got that stiff, rigid appearance to it. Look, rheumatic fever came back up. Like I said, rheumatic fever could be a big indicator of some of these valvular disorders. So that's going to be one of your main causes of that mitral stenosis. A rumbling, apical, diastolic murmur. That's in bold as well. It's hard to tell it's in bold, but I would highlight that as well. That's important. Usually heard during that S2. So we're going to have that low pitch, almost kind of purr type murmur, that kind of swooshing type murmur. Sometimes it's hard for that valve to open up properly, and so as it's trying to open up, it's struggling to open up, it eventually opens up and it kind of has like a snapping effect to it. So we may have this opening high-pitched snap with this type of murmur. All right. Signs and symptoms wise, we might get fatigue, orthopnea, signs and symptoms of that right-sided heart failure. When does my mitral valve open? Distally, I heard distally in the back. Hannah, you're good. That's right. Okay. So let's think about it. The mitral valve is in between the left atrium and the left ventricle. If my mitral valve is not opening up as efficiently as it should, is my blood flow going to be great between the left atrium and the left ventricle? No, right? So what is my left atrium going to do? It's going to back up a little bit, right? But I have that excess volume in there, so that left atrium's got to do something, right? To account for that extra volume. It's going to stretch a little bit, right? It's going to dilate because it's having to deal with that excess volume. After that excess volume, and I'm not able to push that excess volume forward, like Chuck said, it's going to backflow. Where is it going to backflow to? Into the lungs. So back through those pulmonary veins into that lung space. So we're going to have some of that pulmonary congestion, those wet lung sounds. That's why we're getting these types of symptoms. Other things to think about, my arterial pressures. Eventually it's going to backflow into those pulmonary arteries, right? If we let this go on long enough, so we might have those pulmonary arterial pressures start to rise. So remember that back with our Swan-Ganz catheter and how we're wedging our patients. That's how we get that pulmonary artery pressure. So that pulmonary artery pressure is going to increase a little bit, all right? With my pulmonary artery pressure increasing, what's that gonna do even further back? What's past the pulmonary artery, before the pulmonary artery? No, that's the other way.
Pulmonary valve.
What is pulmonary valve? Okay, but a little bit further.
The left or the right ventricle.
Right ventricle, okay? So that right ventricle, remember, it's beating. As it's beating, it's pushing that blood into that pulmonary artery. But if it has all that pressure in that pulmonary artery, isn't my right ventricle gonna have to beat a little bit harder? Work a little bit harder? So eventually, long term, late signs, I might have that right ventricular hypertrophy. Because that heart muscle is having to work extra hard, it's gonna get a little bit bigger. So we're gonna get that right side of heart failure, that stiffer type of heart, okay? So let's talk about it a little bit further. So our mitral valve is gonna be right here, right? Can you all see that? Yep. So the mitral valve is gonna be right here. If it's not opening appropriately as it should, allowing for that blood to go into that left ventricle, it's gonna accumulate within this left atrium, right? With that increased volume, again, my left atrium is gonna have to dilate to make sure it compensates for that extra volume. With all this extra congestion in that left atrium, it's gonna backflow into these pulmonary veins. Remember, our lungs are out here as well. And I'm gonna get all that pulmonary congestion. That's gonna also cause some backflow on this pulmonary artery, increasing those pulmonary artery pressures. So remember, that right ventricle is gonna have to beat a little bit harder to send that blood through because it's getting all this resistance, all this backflow from that pulmonary artery. And that's how we're gonna get those symptoms to develop. That makes sense?
Yes.
Okay. Let's listen to one. happening during diastole, or that S2. And you kind of have to wish the sound. It's very hard to hear it on this computer. You might have to put your headphones in to do it. Just take a note of it. I don't necessarily want you or to feel like you have to diagnose, oh, that's mitral stenosis because I heard it, this little murmur when you hear auscultation. That's gonna be tough to hear as a new grad. But trying to get that in the back of your mind. When am I hearing this? What it's supposed to sound like? I'm hearing it during diastole. When is diastole? During that S2. That's what I'm hearing. That kind of swooshing low per rumbling apical diastolic murmur. That's when I'm hearing it occurring, okay? So all those things are gonna be connected. Questions about mitral stenosis? Okay. Mitral regurgitation. So stenosis was a opening problem, right? So regurgitation is what?
Closing.
A closing problem. For some reason or another, the structural integrity, the structural change, the makeup of my mitral valve is different than it normally should be. With that, my mitral valve does not close appropriately, as it should. Common causes, prolapse. So kind of that elongated side of one of the leaflets of that mitral valve, that bicuspid valve, is kind of overlaying or prolapsing over that other valve as it closes, causing for that leak. We don't have that adequate seal as it should. This mitral valve's got to be pretty strong because as that left ventricle beats, it's got to have all that resistance to stay closed. That left ventricle's pretty strong. It's causing a lot of increased pressure, so it's got to stay closed. Other causes, endocarditis. Maybe a dead section of the heart, so some type of MI, or some type of dilated cardiomyopathy. Again, well, this one's not bolded, but I would highlight the high-pitched systolic murmur at the apex. Systolic murmur. Remember, this is a closing type of problem. When does my mitral valve close? Closes during systole, right? So I gotta have a systolic murmur if it's a mitral regurg. So think about that. We're gonna have that S3 heart sound. So you remember that Kentucky heart sound way back when that we talked about? That can be a later sign of it. Furthermore, fatigue, weakness again, orthopnea. If it backflows enough, we're gonna have that right-sided heart failure again. That right-sided heart failure is gonna be a very late sign of mitral regurgitation as well. So let's talk about it. So again, we're talking about the mitral valve, which is in between the left atrium and the left ventricle. It's not properly closing. That's our problem with our regurg. So some of this excess blood that's occurring in this left ventricle, as that left ventricle beats, it's gonna backflow back into this left atrium. As the left atrium has this extra volume, it's gonna dilate a little bit as well. But on that next beat, that diastolic beat, that excess volume that has occurred or accrued inside that left atrium is now all falling back in to this left ventricle. So now my left ventricle is also having to deal with this excess volume because it didn't pump all the blood from previous cycles. So now it's having to deal with that excess volume to pump it out into this aorta and out to the body. So now my left ventricle is having to work extra hard as well to compensate for that extra volume that's occurring. So we're gonna get some left atrial dilation. We're also gonna get some left ventricular hypertrophy as well because my left ventricle is having to beat a little bit harder, to be more efficient at its job. Once that left ventricle begins to hypertrophy, it can only hypertrophy so much, it can only grow so much, and at that point, we're gonna have that decreased cardiac output. We're gonna have that continual backflow, and then our system is gonna get backed up. So remember, it's gonna back up into the left, to the lungs, it's gonna backflow into that pulmonary artery, and eventually kind of back up into that right ventricle. Then that's how we're gonna get that right-sided heart failure from there. Okay. Questions about how that works? Does that make sense?
Mm-hmm.
Sam, you okay? Yep, you good? This is fun stuff, guys.
Mm-hmm. This is definitely required a shot.
Let's see. So some other light signs of your right-sided heart failure. Remember we said something like a JVD, pitting edema. We also have that S3 Kentucky type heart sound. We also have hepatomegaly as well. So those veins, those arteries around the liver are going to enlarge because of the backflow of blood. There's too much congestion within that, so they have to dilate to compensate. So we're getting an enlarged liver as well. All this plays a factor into it.
And then eventually kidney failure.
Eventually. Kind of hard to hear, but just to give you a good representation. A high-pitched systolic murmur. Where are we hearing that mitral valve again? In the auscultate, where are we listening
The
to?
fifth intercostal.
Fifth intercostal space, left mid-clavicular, right? Okay. Questions about mitral regurgitation? Okay, let's move away from the mitral valve. Let's talk about the aortic valve. Remember, the aortic valve is in between that left ventricle and the aorta, back in there. So as the left ventricle beats during systole, that aortic valve opens, allowing for that blood to flow into that aorta and out through the body. Then during diastole, as the atrials or the atriums beat, it closes up to hopefully not allow for that backflow of blood to occur. So aortic stenosis. So my aortic valve is not opening up as it should. For some reason or another, due to repetitive wear and tear, just kind of stiffening, calcification, again, those types of things. Types of causes, rheumatic disease, that's a big factor again, we're hearing that again. Congenital defects. You're also going to talk about some type of congenital heart defects when we talk about high risk OB toward the end of the semester here. Ms. Hollyfield will talk to you about it. So some of those septal defects as well. But they also have some valvular disease as well. Again, that atherosclerosis, or just that stiffening, calcification around the aortic valve, not allowing for that valve to open up efficiently, allowing for that blood to flow easily, nice and smooth. Highlight that systolic crescendo, decrescendo murmur. Crescendo, decrescendo. What does that mean? Up and down is what I heard. Make sense? Increase and decrease. So the intensity of the murmur is going to increase, crescendo, get a little bit louder, more intense. And then decrescendo, so decrease, not as intense, a little bit softer. Aortic stenosis, systolic crescendo, decrescendo type of murmur. Let's look at what it does to our heart, okay? With aortic stenosis, now we're talking about the aorta. We're not worried about the mitral valve anymore. We're worried about the aorta this time. Remember, aortic stenosis, that valve is not opening as efficiently as it should. My left ventricle is having to work harder to pump that blood up into that aorta because of that narrowing of that valve opening. So if my left ventricle is having a hard time beating as it should, and it's beating harder, that's when we're gonna get that left ventricular hypertrophy. My heart muscle has to enlarge to compensate, to get a little bit stronger from there. If I'm not getting out that blood as efficiently as I should and not pumping out as much as I should, there could be a couple different things. So remember, when that left ventricle beats, it pushes it through the aorta, but then where does it go?
To the one.
Goes, no,
Oh,
to the body, right? Okay. So then I'm gonna get things like fatigue, that peripheral cyanosis, because my body is not getting the delivery of that rich oxygenated blood because of the inefficiency of the left ventricle. I'm gonna get fatigue, I'm gonna get short of breath because I don't have enough of those oxygen molecules running around in my blood because my heart is not able to deliver that appropriately as I should. So that's why I'm getting those signs and symptoms. Eventually, I'm gonna have that fixed cardiac output where the left ventricle is not able to keep up with the demands of the body as it should. And now I can't get any stronger, I can't enlarge anymore, I can't hypertroph anymore. And so now I have that fixed cardiac output. That's the highest my cardiac output will ever go. So it cannot meet the demands of that body. With that, I'm not able to now pump the blood as I should back into that aorta, and now it's gonna backflow into that left atrium. So those real late signs are gonna be that left atrial dilation, that congestion in that lung space, those wet type of lungs, okay? So again, that right-sided heart failure, very late sign. It's gonna be a very late sign for all of these, okay? Other thoughts, another sign and symptom I can have, a narrow pulse pressure. What does that mean? Narrow pulse pressure.
That means your diastolic and your systolic are very close together.
Good, systolic and your diastolic are very close together. I have like 100/99 blood pressure. 1 point difference, that's very extreme. I've never seen that before, but to give you representation, very narrow type of pulse pressure. Questions about aortic stenosis? Okay. Let's listen to one. It's going to be kind of soft. We'll listen to it anyway. Gets real loud, high intensity, and then it decreases. That's systolic, crescendo, decrescendo type of murmur. High intensity to low intensity during systole. That makes sense because my aortic valve has got to open up during systole to allow that blood flow to occur. And that stenosis is an opening type of problem. All right, let's talk about aortic regurgitation. So regurgitation is what? Opening problem or closing problem?
Closing.
Closing problem, right? So that aortic valve is not closing appropriately as it should. It needs to close appropriately. Just for that backflow of blood not to happen. There's a lot of high pressures that are occurring. That's really a big vessel, one of the biggest vessels in your body, that aorta. So we don't want that backflow of blood to occur. So it's got to handle these high extreme pressures as well. Same with your systole as well. It's pushing blood forward, so it's got to open up. It's got to have that nice seal. What things can cause this? So something like an infective endocarditis, very similar to that rheumatic endocarditis that we just talked about. Different bacteria, but infective endocarditis. Again, those congenital abnormalities. Something like a hypertension. Why hypertension?
It's putting even more pressure on the heart.
Good, it's creating more pressure on the heart, right? Because that left ventricle is beating against the force of our blood pressure. So with that backflow of blood occurring, that blood pressure is actually causing that backflow of blood because my left ventricle cannot keep up with my blood pressure. It cannot fight against the forces of that blood pressure. So it's gonna cause that backflow of blood from occurring. Big thing, high-pitched, blowing, decrescendo murmur. This is gonna occur during diastole, all right? So it's gonna start off kind of loud and then it's gonna slowly decrease in intensity. Remember, this is during diastole because that aortic valve has to close during diastole. Remember, closing, regurgitation. When does that valve open and when does it close? Let's talk about why. Very similar to our other valve that we talked about in just a little while ago in our mitral valve, but with our aortic valve again, if we have that regurgitation, it's not opening or not closing like it should, and so we have that backflow of blood to occur. Now I have increased volume inside this left ventricle, and then as that left atrium beats, I have even more increased volume in this left ventricle. So now my left ventricle has to pump even harder, beat even more efficiently to actually send that blood back through. In order to do that, that's how my left ventricle dilates. It gets a hypertrophy, it gets a little bit stronger, or tries to get stronger to compensate for that. And eventually, I have that fixed cardiac output again. My left ventricle is unable to keep up with the demand of the body due to the backflow of that blood. So remember, your signs and symptoms of the backflow all the way through the heart. The later signs are gonna be that right-sided heart failure because of so much backflow from occurring. Drew, what you got?
The nocturnal dyspnea and the nocturnal angina, because they're lying down. More
It's-
likely.
It's hypoxia driven as well, that can cause it. It can also cause some pressure changes and stuff in the heart too, but hypoxia driven. Remember, it's a high pitch blowing decrescendo murmur. So decreasing in intensity. So let's take a listen. I know it's hard to hear it, but let's just take a listen. All of these all of these videos are linked into your Canvas module. So you just go back and you can take a listen to them. Again, I'm not trying to get you to diagnose murmurs right off the bat just by auscultating them, knowing that it's whatever this and that. But you should know what type of murmur causes what. So if the aortic regurg, for instance, it causes that high pitch blowing decrescendo murmur. What does that aortic stenosis create? What does that mitral regurg create? Mitral stenosis, those types of things. That's what I want you to focus on. So if I give you a description, you should be able to say, oh yeah, that's a mitral stenosis. Oh yeah, that's an aortic regurg. Okay? But like I said, the videos are linked in there as well. So let's go back to this again, just to kind of refresh, review what we're talking about. Our big ones are gonna be your aortic, which is your second intercostal space, right sternal border, and then your mitral valve right here. Fifth intercostal space, left mid-clavicular. So if that question says something about fifth intercostal space, left mid-clavicular, in the back of your mind, you should already think, all right, it's got something to do with my mitral valve. Or if I describe the other one, okay, it's got something to do with my aortic valve. Then I can narrow down my results, narrow down my answers. All right? So this is a really good mnemonic. Probably write this down as well, memorize this as well. This really is gonna help you determine when this stuff occurs. Okay? I say Mr. Pass. You also have this one as well. So I say Mr. Pass, which is M for mitral, R for regurgitation, the P stands for prolapse, so you can have regurgitation or prolapse. A for aortic, S for stenosis, which equals systole. So my mitral regurgitation and my aortic stenosis is going to occur during systole. So if I say you have the nurse heard a murmur during systole at the fifth intercostal space left mid-clavicular, now you can say, oh, that's mitral regurgitation. Okay? Does that make sense? Then you have the other one, misARD. So mitral stenosis and aortic regurgitation is going to occur during diastole. So if I tell you the nurse heard a murmur during diastole, and then she heard it second intercostal space, right sternal border, then I know that I have some type of aortic regurgitation based off of that description that I gave. So on your test on Tuesday, when you get your scratch sheet of paper, all 13 of you should write this mnemonic down, right? Memorize that mnemonic. I don't care which one you use of this. misARD is misARD, but please know your mnemonic. So let's get a question going. While auscultating, the nurse notes a high-pitched blowing murmur immediately after S2 during diastole, best heard at the right sternal border. What condition does this represent?
B.
B, aortic regurgitation. Okay? Let's break it down. Right sternal border. That already narrows it down a lot, right? So what's the only thing on the right sternal border?
Aortic.
Aortic valve, okay? So if it says anything about mitral, then I can mark that out, right? So I can mark out A and C completely, okay? What else we have? Diastole, right? So what is my aortic valve doing during diastole?
Well,
Close.
we have Miss All, you know.
That's right. We have misARD. That's what we're thinking about it too, though.
It's closed.
So it's closed, right? So if I'm talking about a murmur and I'm talking about a closing problem, closing problems are the regurgitation parts, right? Okay? So my aortic is not closing appropriately during diastole, so that's why I get that aortic regurgitation. But I also put in here as well, high-pitched blowing murmur. So I also describe that murmur to you as well. So I can give you all the parts. I can only give you one of these parts, two of these parts. I can give you all sorts of things and really change up these questions on you. All right? That's why it's good to know your valvular disorders list. why it's good to know Mr. Pass and Miss R. But I'm probably, more than likely, I'm not gonna give you all three of these things at one time. That's just to show you an example of what is gonna happen. Questions about the type of questions I can ask on valvular disease disorders. Okay. I could probably look up some questions about these two, get yourself familiar with it, get yourself familiar with that, that mnemonic acronym. Okay. Question about valve disorders at all? So after I have diagnosed, or I have my nursing diagnosis, and I've told my physician what I think, how I'm going to get to that point, how I'm going to assess that, that's the key. So what type of past medical history do I have? Past medical history is important, right? What kind of things are important as it relates to valvular disease? Stenosis, okay.
And-
What type of histories? Anything cardiac, more specific. Fevers, increased fevers, right? Strep. So something, maybe they had rheumatic fever at one point. Maybe they had rheumatic endocarditis at some point that has caused some type of valvular damage. Remember that rheumatic endocarditis is a big factor with the valvular disease disorders. Other things, what about some type of congenital abnormality that they didn't get corrected? Maybe other family members had some type of congenital heart defect that they got corrected, but they never knew that it was in their kid. And now that they've grown up, they have some type of valvular damage of some sort. Okay. Are they an IV drug user? That could play a huge role into it. Maybe I start to have that vegetation around those leaflets, those valves, not allowing for those valves